Welcome to our session on time-based evaluation and management services. My name is Stacy Olson, and I'm a certified professional coder with a specialty credential in evaluation and management services through the American Academy of Professional Coders. CPT is the code set that is used to report professional medical services. Evaluation and management codes are included in CPT but are a small portion of the overall code set. CPT codes are developed, maintained, and copyrighted by the American Medical Association. Every attempt has been made to provide you with accurate and current information. However, the coding rules can and do change, and it is always the provider's responsibility to know the state and federal rules and to remain current on payer policies. Today's information is not legal advice or a reflection of any individual health system's policies or procedures. It is not instructing providers in the services they may perform and/or bill. It is meant to inform you of general knowledge and best practices for billing and documenting medical services. Our objectives for today's session will be to identify when it is appropriate to use time as the controlling factor for an evaluation and management service. We will demonstrate good examples of documentation to support time-based E&M codes and also look at a time statement that may not support time-based coding. And we will apply these concepts to a case study to select the E&M codes in each setting. The majority of evaluation and management codes are assigned a typical time by CPT. Time can only be used to select your evaluation and management code when greater than 50% of the intra-service time is spent in counseling and/or coordination of care. I cannot stress to you enough how important it is that providers understand that greater than 50% rule for time-based E&M codes. If the majority of the encounter is not spent in counseling and/or coordination of care, then how much time the provider spent performing the encounter does not matter for coding purposes, and the encounter should be coded on complexity using the three key components, which are history, exam, and medical decision-making. I do anticipate that many encounters reported by pharmacists will be time-based visits due to the nature of the work that you do with your patients. However, correct documentation is key for time-based coding. For outpatient settings, which would be the provider's office, the patient's home, assisted living center, or outpatient consultations, the total intra-service time is defined as the time that the provider spends face-to-face with the patient and/or family. The provider cannot count any pre- or post-encounter time toward the total time of the encounter or the counseling and coordination of care time. Only the time spent face-to-face can be counted for the typical time of the E&M code. Providers cannot count time spent reviewing records and tests or time spent arranging other services or communicating with other providers unless it is done in the room with the patient present. For inpatient settings, which would be inpatient hospitals, nursing facilities, and inpatient consultation codes, the intra-service time is defined as the time spent at the patient's bedside and on the floor or unit. In an inpatient setting, the time spent establishing or reviewing the patient's chart, examining the patient, writing notes, and communicating with other providers or the patient and family can be counted as long as the provider remains at the bedside or on the floor or unit. Once the provider steps off the floor or unit that the patient is assigned to, any time spent performing this type of work cannot be used to level your service for that inpatient visit. Remember that in both outpatient and inpatient settings, it is not just the amount of time spent face-to-face or on the floor or unit that determines using the typical time assigned to an E&M code to report that E&M code. the provider must have spent greater than 50% of that total time in counseling and/or coordination of care for time to be used as the controlling factor. Otherwise, the amount of time the provider spends performing the encounter does not matter for coding purposes. Provider documentation must state the total time that was spent face-to-face with the patient in outpatient settings or on the floor and unit in facility settings. It must also state how much time was spent in counseling and/or coordination of care, and generally providers will document that amount of time as greater than 50% of the total time in either setting. Providers should also document who participated in the conversation, and there should be a very clear description of the counseling content or the activities performed for care coordination. Providers should be specific about the topics discussed or that the patient had several questions that needed to be answered and what they were regarding. If this is not clearly documented, the provider may not reflect why the total time spent for that encounter was medically necessary and leave room for scrutiny by others. Time spent obtaining an extensive history from the patient cannot be counted toward the amount of time spent counseling. For instance, if the provider spends a total of 30 minutes with the patient, but it takes 15 minutes to obtain that patient's history, the service cannot be coded based on time since half of the visit was just spent obtaining a history. The note may contain some additional elements of history, exam, and medical decision-making, but when the majority of the encounter is spent in counseling and/or coordination of care, the visit is most appropriately coded using the typical time. Documentation that does not contain a valid time statement or does not describe the details of the counseling and/or coordination of care cannot be coded using time as the determining factor, and instead would need to be coded on the key elements of history, exam, and medical decision-making. So what is counseling and coordination of care? Counseling is a discussion with the patient and/or family concerning diagnostic test results, explaining why you are ordering a diagnostic test, the patient's prognosis, the risks and benefits of management options, instructions for management, the importance of compliance with the treatment plan, risk education, or any other education given to the patient and/or family. Coordination of care is time spent discussing the patient's condition with other healthcare providers, making referrals to other healthcare providers, or arranging diagnostic tests or other resources for the patient. The typical times expressed in CPT are averages and represent a range of times that may be higher or lower depending on the actual clinical circumstances. The total time spent should be documented as the actual time spent, not the exact time of the E&M code that is being reported or the time associated with the patient's appointment on the provider's schedule, unless, of course, that is the actual time that the provider spent. CPT states that when an actual time falls between the typical times defined for CPT codes, that the provider should select the code that is closest to the actual total inter-service time spent. Now, no one expects providers to watch the second hand on the clock, but I do recommend that the provider glances at the clock when they walk in and out of the room, and if the provider really spent closer to 20 minutes and not 25 minutes in the room, then the documentation should reflect the total time as 20 minutes. This table shows us the codes for outpatient settings for both new and established patient E&M codes. The new patient codes are listed in the first column with their typical time assigned by CPT in the second column. The established patient codes are in the third column and their typical times are in the last column. Many providers think in terms of level 1 through 5 visits in each setting. For instance, the provider might say they performed an established patient level 3, and by that mean that they performed CPT 99213 if they saw the patient in the office. It is important to understand that the typical times vary for any given level of E&M from setting to setting and from new to established patients. For instance, don't assume if you perform a level 4 established visit in the office, which is CPT 99214 and requires 25 minutes of face-to-face time, that a patient seen in their home would be based on the same amount of time for the same level of visit. For a level 4 in the home setting, which is CPT 99350, you would need to document a total of 60 minutes face-to-face with the patient to use that level 4 code. 25 minutes spent face-to-face in the home setting would be a level 2 code in that code family, which is 99348. The same is true for inpatient E&M codes. A level 3 subsequent care visit in the hospital requires 30 minutes of intra-service time, while a level 3 subsequent visit in a nursing facility only requires 25 minutes of intra-service time. Now we know that CPT tells us to code the E&M that is assigned to the closest typical time. But what happens if the actual intra-service time falls directly in the middle of two codes? For instance, let's say that the provider spends a total of 30 minutes on the patient's nursing facility unit for a subsequent visit, and greater than 50% of that time was spent in counseling and coordination of care. We would want to code that service based on time, but the actual time falls directly between 99309 and 99310. So which code do we choose? This has been a long ongoing topic of conversation in the coding industry. And if you work for a healthcare organization, I would encourage you to ask your coders if there are policies in place about how to handle this situation. Noridian, which is the Medicare contractor for Washington State, had a question and answer session that said that when this situation occurs, providers can look to the medical decision making to be the tiebreaker, and I think that makes a lot of sense. Even though medical decision-making does not need to be met to select a time-based E&M code, if the patient's conditions or comorbidities are complex and took a lot of thought process, then you should assign the higher level of E&M code. If the patient is fairly stable but required a lot of time, code to the lower level E&M, in this case 99309. Here are the outpatient and inpatient consultation codes with their typical times assigned by CPT. Again, the typical time varies for each level depending on which setting the consultation is performed in. So let's look at our first case study. Here we have a patient who has several questions regarding the ongoing need for anticoagulation and what is available now versus new oral anticoagulants. She has spent some time researching and wants to discuss her findings with the provider. We see a review of some relevant information and systems for a patient who is being seen for anticoagulation, such as any missed or extra doses, any medication or dietary changes, and abnormal bleeding. There was a ProTime performed in the office that day to check the INR, and she is in range of the INR goal previously established. The provider also states the daily dosage for the patient's warfarin and the total weekly dosage. Continuing with our first case study, the assessment of the patient's INR is therapeutic and stable. The provider does a great job of telling us what was discussed with the patient in their assessment. They state they had a long discussion regarding medication options based on the patient's CHAD score and bleeding risks. Education was also provided on when to call the clinic and how vitamin K foods may impact the patient's INR. But it is truly the very last paragraph on this slide that will allow the E&M for the encounter to be coded based on time. Documentation states the provider spent 30 minutes face-to-face with the patient and that greater than 50% of that time was spent in counseling. She was provided with education on her condition, the treatment options, the risks and benefits of proceeding with the plan, and her many questions regarding treatment and outcomes were answered. All of this is supported by the detailed content in the paragraph above. This is a great example of an encounter that should be and can be coded based on time due to the provider's detailed documentation. This grid is taken from the WSPA auditing tool. We were able to answer yes to all 3 of the questions listed, and therefore we may use time as the controlling factor for selecting our E&M code for the first case study. Our first case study states that the patient is being seen in follow-up for anticoagulation. So we know it's an established patient, but we don't know in which setting the visit occurred. I have circled the codes on this table for the established patient visits in the outpatient settings that would be supported for the time-based statement in the case study. In the office, our case study would represent 99214. In an assisted living center, we would have 99335, and for a home visit, we would have enough time to support 99348. The only difference between outpatient and facility time-based coding is how the provider calculates and documents the total intra-service time. In a facility setting, the provider gets to count the total time as the time spent on the floor or unit as discussed previously, and documentation should reflect that the time was spent on the floor or unit, not just face-to-face with the patient. So if we take the same case study we looked at for the outpatient setting and change the face-to-face text to the words floor or unit, we now have documentation to support inpatient time-based coding when the patient is seen in a facility. It would not be inappropriate to document that 30 minutes was spent face-to-face or at the patient's bedside in the inpatient setting if that's where the entire time was truly spent. But if any of the time was spent elsewhere on the floor coordinating care with nursing staff, documenting in or reviewing the patient's medical records and/or testing, then the more accurate statement is to say that the total time was spent on the floor or unit. For the inpatient hospital or nursing facility codes, the actual time of 30 minutes falls directly between the typical times assigned to the E&M codes, so rounding to the closest code cannot be used in this case. However, if we follow the guidance from Noridian that says to look at medical decision making, this patient is at goal and their INR is therapeutic and stable. So I would recommend that this be coded to 99232 in the hospital setting and 99309 in the nursing facility versus to the higher codes of 99233 or 99310. Consultation codes follow the intra-service time of the location that the consultation is performed in. If the consultation was performed in an outpatient setting, the total time would be calculated using only the face-to-face time with the patient. And if it were performed in an inpatient setting, it would follow the floor and unit rule for the intra-service time. Assuming that our case study was a consultation, the codes for an outpatient consultation would be 99242, and for the inpatient setting, our time of 30 minutes falls directly between the two codes of 99251 and 99252. I have chosen to code the 99251 as the provider documented the patient's condition as stable and therapeutic. Our second case study is an 80-year-old female seen in the office, and she was referred by Dr. Bruce Wayne to review and discuss therapy options for osteoporosis with the goal of starting bisphosphonate. The patient had been flagged by her insurance company as having a previous fracture but no osteoporosis therapy. She did have surgery related to a spinal fracture last year, but stated she was not aware that the surgery was related to a spinal fracture. The provider documents that she discussed the surgeon's prior notes with the patient and that the surgeon had recommended that the patient have a DEXA scan and therapy post-surgery, but it had never been done. She did have the DEXA in late January. The results of the DEXA had been briefly discussed with the patient previously, but they were reviewed in detail during this encounter, and the patient had started miacalcin in early 2015 after her laminectomy, but more effective therapy is needed based on the DEXA scan results. They discussed different options for treatment and the risks and benefits of those treatments. The current recommendation is to start the bisphosphonate to maximize bone density, and the patient is in agreement but would like to finish the new bottle of miacalcin that she just got before switching to the new medication. Her supplements were updated and they discussed taking cranberry and its effects on the patient's INR while she is on warfarin. So far, this is looking like great documentation to support a time-based E&M code, as the provider has gone into great detail about the counseling content. The provider included the DEXA scan results in the note and a list of the patient allergies, which are shown on this slide. We do see that the spine could not be evaluated due to the patient's prior spinal fractures, but the T-score at the hip and forearm are consistent with osteoporosis findings. The provider also included a full list of the patient's current medications and supplements in the chart note, which is ultimately just good quality documentation, but has nothing to do with time-based coding. The provider documents the patient's current vital signs on the day of the encounter, and in the assessment and plan goes on to more thoroughly describe the treatment plan. The patient will start Fosamax 70 milligrams weekly, and potential adverse effects were discussed, as well as how to take the medication and monitoring education. The prescription for the Fosamax was sent to the patient's pharmacy, and she will continue to exercise regularly. As soon as the miacalcin is finished, she will begin taking her Fosamax, and outreach will be performed in 1 month to follow up on the therapy. And then we see the provider's time statement. 25 minutes were spent today with greater than 50% face-to-face contact. So let's go back and look at the time-based billing assessment in the WSPA auditing tool. The first question asks us, does documentation reveal the total face-to-face or the unit/floor time? The provider in the case study documented 25 minutes were spent today with greater than 50% face-to-face contact. So the answer is no. We don't know exactly how much time was spent face-to-face with the patient. The second question asks, does documentation state that more than half of the face-to-face or the unit/floor time was spent in counseling or coordinating care? The answer again is no. The provider never stated that greater than 50% of the total time was spent in counseling or coordinating care. They stated that greater than 50% of the total time was spent face-to-face. This is not a good time statement for time-based coding, and even though the provider does give a very detailed synopsis of what the counseling content entailed, I would not code this service based on time. Instead, I would go back and audit this provider's documentation and use the history, exam, and medical decision-making components to build the code based on complexity. Here are my sources for this session. I recommend that you read them for yourselves for a thorough understanding of the guidelines. If you work for a healthcare organization and have a coding educator available to meet with you, I would encourage you to do so to understand the organization's policies and procedures regarding E&M coding. Thank you for listening to our session on time-based evaluation and management coding. I hope that it has helped you to feel confident about when to use time-based coding and the documentation that will be required to support a time-based E&M code.